Present a 60-year male laborer of low socioeconomic status who presents with history of fall from the tree, after which there was pain, swelling, loss of function around right hip since last 3 months. He can neither squat, cross-legged, sit or bear weight, and 2 days later he was operated, and thereafter he has not been able to walk. The past history, the personal history is not contributory. Implant was done 2 days after surgery, 3 months back. Family history is not contributory, except that the patient cannot really bear the cost of management and his job is lost. General examination, the patient is anemic. Systemic examination not contributory. Local examination lying. Fully exposed on a hard bed. Consent taken, private parts, privacy protected. On inspection, the Xiphi sternum, the umbilical central, no lumbar lordosis, ASIS on same level, swelling and raise of the right trochanter, wasting present, flexion adduction, external rotation deformity, attitude, flexion adduction, external rotation attitude, true shortening, SLR negative, dorsiflexion of ankle not positive. On palpation, the findings of inspection are confirmed. The trochanter is thickened, tender, raised, transmitted movements are present, temperature is not raised, telescopy is absent, vascular sinus Narad is negative. Movement normal on the right side, flexion, adduction, flexion range 10 to 60, adduction 20 to 30, and external rotation 10 to 20 degrees. Measurement 3 centimeters of true shortening above the trochanter. Same as the apparent shortening. Morris's bitrochanteric test is negative, but rectal examination was not done. My diagnosis is 60 years old male, post-injury, malunited intertrochanteric fracture right side. Why trochanteric? Because there is a history of injury, the flexion, adduction, external rotation deformity with true shortening, straight leg raising is negative, trochanter is thickened and tender. I can't say united because there is tenderness present, SLR is negative. But only 3 months have passed, therefore it can be delayed union or non-union. The tenderness can be because of infection. It is if it unites in this position, it will be malunited because there is a flexion, adduction, external deformity with true shortening. Differential diagnosis is infection, an infected implant. To assess the general condition of patient, I will do a hemoglobin, DLC, ASR, GBP, PT-CT, blood urea, blood sugar, urine and stool. I will judge the fitness for anesthesia and surgery by an X-ray of the chest, by electrocardiogram, and by reference to medicine and anesthesia. I will take an X-ray of the pelvis, AP view with both hips in identical position. But the X-ray available is an X-ray of the right hip, where I see a proximal femoral nail in situ. The lesser trochanter is fractured, but there is no evidence of non-union. There is still union process going on. The fracture between the trochanter and the shaft is there, but there is no evidence of non-union. There is radiolucency around the nail. There is extrusion of the femoral screw, and this suggests that there is infection. I will treat the patient by removing the nail by culture sensitivity. On the operation table, I will try to confirm union. If it is not united, I will freshen the fracture ends, remove any interposed tissue, put in a bone graft only if there is no infection, and immobilize by an external fixation. If the fracture is united, if there is infection, I will put in antibiotic beads, antibiotic cement, or antibiotic covered nail. Alternatively, I can do suction irrigation according to culture sensitivity. In case the fracture is united and not infected, I will put in a graft.